that is going to be talking to us about a subject that's near and dear to my heart. I don't know how much money I've spent trying to learn how to do ultrasound. I still can't do it, but I keep hoping.
Thanks. Well, as you see from the title, I'm going to talk about how we've gone from a period where we could get hemodynamic information from a PA catheter, and then through some botched-up studies, we no longer have PA catheters. So we had to find some replacement for assessing the hemodynamics in our patients. And echocardiography has stepped in to fulfill that role. So no disclosures. What I am going to do today is I'm not going to make echocardiographers out of you. You're probably going to not remember any of the details that I have, but what I want you to remember is what can we do with echocardiography, kind of how it's done, and then down the road, if you're interested in getting more skilled at doing this, then you can pursue that independently. But it's pretty amazing at the extent of what we can learn about hemodynamic function using usually just transthoracic echocardiography. And we don't usually need to go to transesophageal. But yeah, I guess to start a talk on echocardiography, what we're going to look at focused echocardiography. That is, we have specific questions to answer. What is the preload? What is the contractility of the heart? What drug do I need to pick to help my patient? Do I need to give them fluid? This is a much more limited exam than a traditional full echo that's done by cardiologists. I just look at everything from stem to stern. So we're going to spend less time at the bedside. We're going to get in, get our questions answered, and get out. And we're going to go back in repeatedly to assess our response to therapy. If you try to get an echo from cardiology less than 6 months from the last one, you're going to get some pushback. So this is a skill that has to be taught at the bedside, and it is now officially incorporated into critical care training programs. So critical care fellows moving forward, it's always been in our program ever since the inception some 25, 30 years ago. But it's now required by the ACGME for critical care training. The four views, the standard views are what we follow. These are the same views a cardiologist use. We place the probe to the left of the sternum in about the fourth intercostal space, and we can aim the beam in this direction here, along the long axis of the heart. So it goes from the right shoulder down to the left leg. That gives us a cut right through the left and part of the right ventricle and gives us this image right here. We may have to move the probe down or up an inner space or two to get a full evaluation of all of the left ventricle, because you may not see it entirely at one inner space, as demonstrated right here. This one looks more at the base of the heart. You can move it down and get more of the apex of the heart. But we're cutting right through. We're seeing a longitudinal section of the left ventricle. So we see the septum, posterior wall. We get a glimpse of the right ventricle, and we see the two valves of the left side of the heart. And that's what you see right here. This is not the greatest picture. You'll see better ones, but this is the mitral valve. That's the aortic valve. You can see this open. There's one of the leaflets. You can see, as you'll come to see in this lecture, that this is a dilated heart. That's a pretty big LV. It's probably got a cardiomyopathy and the dilated left atrium. But nonetheless, this is the view. This is one of the views that we start with. This allows us to get some idea of contractility as well as valvular structure. We can then take it, the transducer, leave it in the same inner space and just flip it 90 degrees. And now we're doing a cross-section of the right and left ventricles. This gives us a good view of the entirety of cross-section of the left ventricle, so we can look to see how well it's contracting, and we can make measurements of its diameter and so forth. So we'll start with the previous one. We'll go to the short axis view and get some images there. We can tilt the transducer up towards the base, and we can catch a glimpse of the aortic valve, the right ventricle, the pulmonary artery, the pulmonary valve, if we're so interested. If you want to see a big saddle embolus, you can pick it up. right up in the outflow tract or further beyond. You don't really see emboli very well on transthoracic, but you can pick them up if they're proximal clots. You can pick them up very easily on transesophageal because they get a much better view of the valves. So we'll use this to assess volume and contractility. And this just shows it at the level of the mitral valve. You can see the anterior and posterior leaflets. Or you can go a little more towards the apex and you can see the anterior and posterior, anterolateral and posterior medial muscle bundles, papillary muscle bundles. We can then move down to the apex. Now this is one that's hard to get in critically ill patients, especially on a ventilator, because if you get on a ventilator and get positive pressure, the lung gets pushed up between the heart and the chest wall, especially near the apex. So this is, in critically ill patients, this is hard to get. But if you can get it, it gives you a lot of information. This shows, this is done probably about the fifth intercostal space in most patients in the anterior axillary line. But it may vary in position depending on if they have cardiomegaly and so forth. In the echo lab, what they'll do to facilitate this view is they'll turn the patient on the left side, and that brings the heart up against the chest. So that's something we sometimes do in the ICU when we can't get a good view. But this shows all four chambers of the heart, and hence the apical is called the apical four-chamber view. This is where we take the transducer and we aim it up a little bit higher, and we bring in the aortic valve. This is the aortic outflow tract, and view is important because this is how you'll measure cardiac output by using Doppler on the aortic valve right here. Okay? That's a two-chamber. You have to get it in line with the ejection of the heart. So you can't really get it from these views here because you're not in line with the aortic valve, you're perpendicular to it. The subcostal, you're off at an angle on the subcostal. This is the subcostal view here. So you might be able to get it subcostal, but usually the apex, instead of being here, is off to the side and it's too much. And I'll show you what limitations are and when you can trust that measurement or not. The subcostal view we use a lot in critical care because it may be the only view of the four chambers that we can get. The apical view, if that's not visible, we'll jump to the subcostal view. And you get something very similar to the four-chamber view, except it's instead of the apex being here, it's tilted a little bit. But you can now see the RV and the LV. And this is a good view for looking at the size of the RV. We want quick and dirty answers. So I want to know, is that RV big? Is it small? How is it relative to the LV? And I'll talk more about how we use that measurement. And this is a cross-section. So this is similar to your parasternal short axis. This just shows you the LV in cross-section and the RV in cross-section. So if you don't get a good cross-section view of parasternal short axis, then you can get that subcostal. And again, assessing RV and LV size is what we do here. So this is just it's supposed to be a movie. See if it works. Yeah, we do have old technology, but this old technology is working. Good. So we're looking at contractility. Here we can see the septum is contracting well, and the posterior wall was contracting well. This is the short axis. You can see that it's going by very quickly. But you can see that it's contracting symmetrically, that it's got a good ejection fraction just by eyeballing it. I mean, just from experience, I can tell you that was about a 60% ejection fraction. So once you get used to looking at these things, you can get a lot just by eyeballing and not have to sit down and go make all the measurements that may otherwise be necessary. So one of the things that we can use echo for, and we use it for a lot, is does my patient need fluid? What is their volume status? And we can get a lot of information from echo. We can look at the right ventricular size. The right ventricle is normally a little smaller than the left ventricle. If it's very small, if it's less than half the size of the left ventricle, then we say, their volume, their preload is probably low. And if it's larger than the left ventricle, then we have right ventricular volume overload. You give that patient fluid, you're going to put them into a downward spiral. So it can help you assess who needs fluid and who should not get fluid. We can look at the inferior vena cava. We'll talk about that. We'll look at the LV dimension. That's just we often eyeball that, but I'll show you how we can get a little more specific. And I already mentioned detection of RV overload by looking at the right ventricular size. We also can use Doppler. Doppler is a little extra skill above regular 2D echo, but it's really not that hard, and gives you a whole lot more information, and I'll give you examples of what we can get from that. So normally your end diastolic diameter, if you were just to put the measurement probe across the LV on like a parasternal axis, it should be 3.5 to 6 centimeters. If that's bigger than that, they've got an elevated end diastolic volume. It's often seen in cardiomyopathy. And the RV is normally less than 0.5, the size of the LV, but in critical illness, we shoot for 1/2 to 1. We want the RV to be a little bit more full because then we know we're not hypovolemic, because a critically ill patient with a small RV is probably hypovolemic. Then we can look at M mode. M mode is, M stands for motion. What we'll do for M mode to look at, for example, the left ventricle over time is this is a parasternal short axis. So at the left of the sternum, turn it across the cross-section of the heart. So this is a cross-section of the LV right there. And when we turn on M mode, it gives us a line. We just put that line right down the middle of the ventricular chamber. Center it right on the LV. And that gives us, this is depth, and this is time. So this is a motion study of the structures. And this is the septum right here, and you can see it contracting with systole. And this is a posterior wall. You can see it going up, contracting with systole. It gives you a more quantitative assessment of how much contractility is going on. And here you can see the right ventricular free wall is not moving very much. The RV is hard to visualize on echo, but it often doesn't move nearly as much as the LV. And I'll show you can actually make measurements from that. So this is the IVC. I think this should be a movie. Yep, it's a movie. Okay, here's the inferior vena cava. You can see it's distended. It's not collapsing. And you can see it collapse with respiration. You see it moving in and out with respiration. And an IVC that's full and only partially collapses during inspiration or positive pressure ventilation is normal. If you see an IVC that does not distend, does not decrease in size at all, you know they've got plenty of volume on board, and they may very well be volume overloaded. And if the IVC is flat, as I'll show you in a minute, then you can pretty much say this patient needs fluid. I don't need to do anything else. So the IVC gives you a lot of information. In this situation here, which looks normal in size and normal distensibility, we don't know if that patient's going to respond to fluid. This is what we expect in a normal patient, but in a critically ill patient, if we see this, you can't say he's volume normal. There are other indices we look to see if they're volume responsive. So we can say his preload is probably normal, but that does not mean that he won't respond better to additional fluid. That's an ECMO cannula. Yeah. He what? Yeah. Yeah, this is a sick patient. And then in hypovolemia, you can see that this IVC is very small, and it's collapsing most of the way with inspiration. Okay. Yeah, we're looking at it. So this Sorry to have you not oriented. The patient's feet are to the left out here. This is the right atrium. So this is the IVC coming into the right atrium. Okay? This is a hepatic vein. So there's a diaphragm right there, and there's a liver. The lungs will be up here, and this motion here is part of the free wall of the atrium. It's not really showing the atrium very well because of the contrast, but this is the left atrium right there. Right atrium right there. And you can see this is almost totally collapsing right in here with inspiration. So this patient is probably going to respond well to some fluid administration. If you want me to go back here, again, the right atrium is here, but you can see that's fairly well dilated. And if you want to get technical, you can measure the collapsibility. You can do M mode, which shows you things over time. So you just shoot the IVC, shoot the M mode right through it. And you can freeze it, and you can make a quick measurement of the IVC at the 2 phases of respiration. And you can look at how much it changes in diameter, and I'll show you a chart as to how that's helpful. This gives you, looking at how much collapsibility you have, gives you a little bit more precision when you're looking at volume response at preload, and this is what this shows here. So basically, you're looking at what the percent of distensibility, or the percent change in diameter. And if you have a value in a normal breathing patient of around 15 to 20%, that's what you expect to be normal. So if they're collapsing more than that, then they may be volume responsive. If they're collapsing a lot, then that's going to correlate with a very low central venous pressure. So all of these give you a crude guideline, and I'll simplify these for you by giving you 2 numbers that you can take away instead of all these numbers here. If they're breathing spontaneously, now the trick to using the IVC is they have to be quietly breathing. If they're tachypnic, you cannot use the IVC at all, because every normal person will collapse their IVC with rapid respiration. So they have to be breathing quietly, spontaneously, in which case if it collapses more than 25%, give them fluid. If they're on a ventilator, 50% for breathing spontaneously. If they're on a ventilator, if they're collapsing even 25%, they may be fluid responsive, so give them fluid. So that's kind of how we use the IVC. We can also look at the right ventricle. This is really not a great shot. I don't have the lights low enough to really see this. But what this is intending to show is that the right ventricle, this is the parasternal short axis. Is that a little better? Okay. This is a parasternal short axis. So there's the left ventricle right there, and you can see the right ventricle is small. And here, that's also hypovolemia. I don't see what's that, but yeah, I'm sorry. I'm not going to. These are movies, actually, so it might be able to see it a little bit better. Okay, what you're seeing here is the following. This is the left ventricle here, and if you look at that, if you look at it contracting, it's almost completely contracting. It's not filling very much, and it's completely contracting. So this left ventricle is just not getting enough fluid. And the right ventricle is not big. It's small, too. So this is a hypovolemic patient. This patient will respond to fluid. Let's see. And this is the IVC. It's not a really great shot. I'm going to skip it in the interest of time. But these are intended to show you that the IVC diameter improves. Okay, this we don't do. But if you're interested and you really wanted to know the volume of the ventricle, there are ways on the echo machine where you can actually map out the volume of the ventricle for precise measurements of volume and cardiac output. But we don't do that in focused echocardiography. I want to reintroduce you to the Doppler effect. What Doppler does, it's based on the equation that shows that if you have a velocity of something moving away or towards you, it's going to shift the frequency. If it's moving away from you, it's going to increase the frequency a small amount. If it's moving towards you, it's going to decrease and then increase if it's moving towards you. The classic example is you're standing by the railroad track. A train is coming towards you. It's a little higher pitched. When it passes by, the pitch immediately drops to a lower pitch. That's the Doppler effect. And so we use that with ultrasound to measure velocity, and that's what Doppler's for. All it's doing is measuring velocity. And we can target particular areas to measure velocity from. The two types of Doppler, we usually keep things simple and use the pulse wave because that's what the machine defaults to. Pulse wave, all that means is that the electronics send a pulse and then wait for a return signal. And it can accurately allow you to adjust the depth of where you're making your measurement. And it's shown here as a square or a bar or something. So you can use the controls to move this anywhere you want in the heart. And you can therefore measure velocity anywhere in the heart just by moving it. Continuous wave is a little better for looking at peak velocity only. If all you're worried about is the peak velocity, then you want to use continuous wave because it does not matter. It will find the peak velocity anywhere up in here. It's a little more sensitive for doing that, and that's why it's often used. And it's used for things like peak velocity during the tricuspid regurg and so forth. But I personally rarely use it. I just stick with pulse, even though I lose a little bit of precision because the machine's already set in that mode, and I know exactly where I'm making my measurement. But in the echo lab, you'll probably see him using this. But putting the echo machine into a pulse Doppler mode gives you your image at the top, the B mode, the 2D echo, and then it gives you the Doppler tracing at the bottom. Then you can move your probe around, your Doppler probe, anywhere you want and make measurements. Here it's sitting at the aortic valve, so it's measuring aortic outflow. Okay, we went through this already. Our color flow. Color flow is not very quantitative. It gives you a rough idea of what velocities are, but it's mostly used just to kind of give you a bird's eye view of what's happening. And it helps me to locate areas that would be hard to locate otherwise. This is an example of a color flow. This is a 4-chamber view. There's the left and right, the left ventricle and the left atrium, and this is the right side. There's a tricuspid valve. There's the mitral valve right there. And color flow gives you color information. The blue is away from you. You can see the blue down here, and the red is towards you. So what this one is showing here is that there's blue, which is the filling of the didn't mean to go that far. Let's see. This allows, I'm just going to do it very quickly, this allows you to look at the direction of flow. This is red coming in from the pulmonary veins, and this is blue out here because it's heading down the outflow track. But it just lets you map things out. And what I use it mostly for is to look for regurgitation and to identify the jet on the tricuspid valve, and I'll talk more about that. Another way to get a quick view is to look at right atrial filling using Doppler. This is kind of the equivalent of stroke volume variation, which you're familiar with. If you do get the IVC, this is the right atrium, this is the IVC, you find a hepatic vein that's going directly away from the transducer, and you put a pulse Doppler right in there, you can see the flow in the hepatic vein. And that corresponds to the flow in the inferior vena cava. And so you can look at variation. If you see variation in flow, That's the same mechanism as stroke volume variation. So this is a real crude way to say that this patient might benefit from some fluid administration. It's very easy to do because it's very easy to hit that hepatic vein. It's one of the simplest Doppler techniques you can do. And you can see the change in size from during the respiratory phase. The diameter? Yeah, the change in diameter is not as reflective of the actual volume change as Doppler is. Right. Yeah, in the IVC itself, it's perpendicular. So you have to hit the hepatic vein because it's coming longitudinal to your transducer. If you're not, if you have flow that is perpendicular, you measure 0. And to get most accurate flow, you have to be within, as I'll show you, 20 or 25 degrees. Another thing we can do to help give us some idea of volume assessment is to do the apical 4-chamber view. You've seen that a bunch of times. And then Doppler the mitral valve, or in the LV, just inside the mitral valve. So you're looking at flow through the mitral valve. Normal, you see an early filling wave and an atrial contraction. It's called the E and A waves. Early filling is passive filling. When the valve opens during diastole, you get passive filling, and then you get your atrial kick. Okay? If you're hypovolemic, you're not going to have much venous return, so your early filling wave is going to be small, and you're going to get more bang from your buck from your atrial kick. So normally, your E wave is greater than and up to 2 times higher. If you see it much, much higher, like shown here, you're probably dealing with a pericardial restriction or cardiomyopathy or something like that. But if you don't have any underlying cardiomyopathy, this will give you another clue as to if they're hypovolemic. Because if you see this pattern here instead of this, they're probably going to be fluid responsive. And here's where you measure it. You measure just inside the mitral valve. So you do your apical 4-chamber, and this is actually reversed. This is probably from a Mayo Clinic publication. They're the only place in the country that reverses their echoes. And normally the LV is shown on this side. So you would put this right at the mitral valve leaflet tips. And here's a low E to A. And here's a normal E to A. And here's a high E to A. So this would suggest hypovolemia. Okay, I'm not going to skip over that. I want to talk about ventricular interdependence because this is something that will allow us to pick up patients that if you give fluid to, you can kill. This is one of the few cases. This is a volume overloaded patient in terms of the right ventricle. This is the right ventricle here. It's huge. And when it can't expand anymore because of the pericardial sac, it pushes on the left ventricle. And here you see the septum. It should be round. The septum is actually pushed in. So this is such severe right ventricular overload, which can be just from fluid to excess resuscitation. It can be from obstruction like a pulmonary embolus with extra fluid. But this causes a severe compromise of the left ventricle. So volume overloading can contribute to left ventricular dysfunction and give you hypotension. And this needs to be treated. And when we see this, if they're stable, we can diurese them. If not, we have to resort to something more drastic. And now you see the same patient, after volume removal, they've now restored their ventricular size. The ventricle is able to fill better, and they get better hemodynamics. So this is something you can pick up very easily at the bedside. Okay, I'm going to skip that there. It's going to show you. This is normal myocardial function, just so you can eyeball it, because I'm going to compare it to a ventricular dysfunction. So this ventricle is contracting about 25 to 30%. That's equal to about a 50% ejection fraction. That's normal. And look at the next slide, which is a severe cardiomyopathy. And this is an apical, this is a long axis. Oops. Let's see, You can see here, you can eyeball very easily. Here's the septum. It's kind of contracting, but it's not moving in. Here's the posterior wall. It's moving, but it's not moving in. This patient's ejection fraction is about 10%. This is a severe cardiomyopathy. If you had to support this patient, this is the one where a vasopressor would probably do more harm than good, and an inotrope is what you need. Okay? And you can see it's severely dilated just by eyeballing it. You don't have to make any measurements. Just to show you how, if you wanted to, you could measure ejection fraction from an echo. And it's pretty straightforward. All we do is like the parasternal long axis or short axis, we measure the left ventricular dimension, and we measure it at the end of diastole and the end of systole, and just plug in this simple equation. And as long as the heart is contracting concentrically, this is a pretty reasonable measurement of ejection fraction. And that's how it's done in the echo lab. But again, do I do this? I only do it for teaching purposes, but at the bedside, I just eyeball the ejection fraction and say, okay, they've got poor contractility, normal contractility, or high or excessive contractility. So you don't need to go through all of that. Something else we can do, I don't do it very often, but if you have myocardial ischemia, this might be a perfect example, a trauma patient with a contusion who has got injury to a region of the myocardium. You can pick that up. In patients with coronary disease, we can actually look at mapping out which coronary circulation is affected, because you'd expect the myocardium to contract evenly, but if portions of it are not contracting or contracting poorly, that is, in certain regions, that may represent ischemic heart disease. And that's one of the things the cardiologist will look for is, are there any regional wall motion abnormalities that might suggest either acute or chronic coronary ischemia. You can't tell acute from chronic because they can have poor function from either one, but looking at which region is involved can give you a clue as to which coronary function. Okay, this is a pericardial effusion, and this is parasternal long axis. So this shows the septum here. You're not seeing the right ventricle very well, but there's the septum, posterior wall, mitral valve, aortic valve, but now we have the heart being pushed up by a large posterior pericardial effusion. So you know this from your FAST exam. That's one of the things you look for using ultrasound. So that is nothing new, but where you can go a little bit further, and if you pay attention, you can identify if this effusion is causing tamponade. Not all effusions cause tamponade. So one of the things that define tamponade is an equalization of pressures. And if you have equal pressures in the effusion as you do in the heart, then you lose your distending pressure in the ventricle. And you can get collapse. Here's a right atrial wall collapse, and there's a right ventricular wall collapse. If you see that, that's pretty pathognomonic diagnostic of tamponade. And this is a patient you need to treat very, very early. Here's what I use echo for a lot, and that's to get an estimate of stroke volume and cardiac output. We have since we don't PA catheters much anymore, we do have these pulse contour devices and cheetahs, but they can be way off. They are not critically ill patients. They can be 100% off. So I never use those and trust those until I've validated it by some other technique. And usually I just do a quick look with echo to see if what the echo shows me is close to what the non-invasive or other device is. And using Doppler, we can easily measure stroke volume and cardiac output. And the principle is this. If we look at the velocity of blood coming out, for example, in the aorta, coming out across the aortic valve, this is during ejection. You can see it, the velocity increasing and the velocity decreasing, okay, over the ejection period. this is velocity, this is time. So if we were to take the area under that curve, we would have the product of velocity and time, which is what? Meters per second times second equals meters or centimeters. It's distance. The area under that curve tells you how far the blood is being ejected out of the heart on the average distance that the blood goes. If you know the cross-section of the area that it's moving through, the aortic valve, you now can multiply those two, the cross-sectional area times that volume-time integral, which is easily obtained, and I'll show you, you get stroke volume. That's a pretty accurate measurement of stroke volume. Multiply that times heart rate, you've got cardiac output. So that's what I can use to sort of calibrate these flow tracks and cheetahs to make sure that they're giving me the data that I think they are giving. So this just shows a rough example. You just take the Doppler and then Doppler from the four-chamber view, the aortic valve, and you can, the machine does a trace, an LVOT trace, left ventricular outflow trace, and you just run your cursor right around that curve and it pops in with the VTI, which is right there. This says 17.36. That's normal. Normal's around 18 or 20. And if I wanted to go further than that, I could actually measure the aortic valve, the left ventricular outflow tract, calculate that area from the diameter, and I've got stroke volume. Do I go that far? Not usually. I'll usually stop right here. For teaching purposes, I'll go on and show that. But here I'll just look at the VTI, because the VTI scales with size. So if you have a normal VTI of 18 or 20, your cardiac output is considered fairly normal. If it's 25, you're hyperdynamic. Your stroke volume is high. And now remember, that's your stroke volume, not cardiac output. So your stroke volume is high. If it's 18 or 20, it's normal. If it's down around 15, you're starting to get diminished. And if you're down below 15, especially 10 to 12, you're significantly diminished. So if the VTI is 10, I know their cardiac output is roughly half a normal. At least their stroke volume is roughly half normal. Okay? So this is one of the most important measurements we make. And some of the new ultrasound machines, I'm not going to mention the brands, you can talk to me afterwards, but one of the brands actually does all this for you automatically. You don't even have to get the Doppler view. All you have to do is find the aortic valve on a 2D, and it will go in and do the automatic Doppler and automatic VTI and pop it out for you. So you don't even have to have the skill to do all that. You can do it as done by the machine. That's just a review of the calculations, and I don't think I need to go. But here are some of the pitfalls in using that calculation. The weakest link in the calculation for accurate measurements of stroke volume is the cross-sectional area. Okay? But VTI is pretty accurate. And even if you don't want to bother with measuring this, as I told you, values you could use to give you a rough idea of what the stroke volume is, it tracks changes very well. The VTI will track changes. So if you put them on a vasopressor and inotrope, you can see what the change in their cardiac output is by just the change in the VTI. If you get a 30% increase in VTI and the heart rate's the same, you've got a 30% increase in cardiac output. Okay? And it measures, the other consideration is it only measures forward flow. So if you have some regurgitation, it's not able to subtract that regurgitant flow from the forward flow, so it may actually underestimate the true forward cardiac output. And again, it's sometimes hard to find a window to measure the VTI. TEE always allows you to do that, but transthoracic, you may be limited. Another way to measure a fairly accurate measurement of stroke volume variation, which we now know is a very reliable predictor of fluid responsiveness. not of preload per se, but will they respond to fluid? And the SVV, if that's elevated and you're measuring it under the right conditions, is highly predictive of fluid responsiveness. And all you have to do is measure the VTI on a signal that's the largest and a signal that's the smallest, which varies with respiration. Just get the difference in the VTI divided by the average of the two VTIs, and you've got stroke volume variation. Same thing you get from the flow track, but you don't have to. This is non-invasive. And as an aside, even though it's not echocardiography, there was a study that looked at carotid artery VTI and measuring stroke volume variation from that, and it was pretty much as accurate as using echo. So you don't have to know how to look at the heart. You can get stroke volume variation just from the carotid. And another study subsequent to that showed that the peak velocity in the carotid was almost as accurate as getting the VTI. Yep. So, but it's a variation. So even if you have stenosis, you're looking at variation with respiration. So you're looking at the change. And so all you have to know is how to measure a peak velocity with Doppler in the carotid, and you can assess them for an elevated stroke volume variation. Okay. Now we're often interested in pulmonary hypertension because that's an important aspect, pathophysiology in our critically ill patients, so we can get an estimate of that. If you do a color Doppler on the 4-chamber view, you can probably pick up a regurgitant jet. Here's a tricuspid regurg. Tricuspid regurg is present in almost all critically ill patients. Anytime you get a little bit of dilation of the right ventricle, you're going to have some tricuspid regurg. Maybe trivial, doesn't have to be much. Once you identify that regurg, you can, this is a lot, and this is a little, then you can Doppler, you can then switch from color mode to Doppler and put that Doppler probe right inside that jet, and you can measure the regurgitant velocity. And you look at the peak velocity, here it's 150 centimeters per minute per second, converted to meters, 0.15, and then all you have to do is square that, multiply it times 4, and you have the gradient across that valve. So if you have a 1 meter jet, 1 squared times 4 is 4. You know you have 4 millimeters of mercury across a valve. That's normal. But if you have a 3 meter per second jet, 3 squared is 9. 9 times 4 is 36. They're getting pulmonary hypertension. And this is how the cardiologists do it. So this value here, this product is the gradient across the valve. So if you want to know what's happening in the pulmonary artery itself, then you have to add in what the right atrial pressure is, because this is the gradient that because the right atrial pressure. This is a gradient without the right atrial pressure. So if you have an estimate of the RAP, you might think, oh, it's probably 5, 10, 15. You can throw that in, and you can get a rough idea of whether they have pulmonary artery hypertension. Okay, I think I need to go through that. If you are interested, there's a technique to estimate wedge pressure, but nobody cares about wedge pressure anymore. So, but just in case you're interested. So, in summary, using invasive monitoring, by that I mean pulmonary artery catheter monitoring, we can get a lot of measurements. We get a continuous measurement of cardiac output. We can get a preload measurement by looking at a right ventricular end diastolic volume. We can intermittently measure wedge, but it doesn't mean anything, so we don't do that. Pulmonary artery pressure, you get a continuous measurement. You can get a rough idea of your LV systolic function. This is a left ventricular systolic work index, a calculation from the PA catheter. So it's indirect, but it kind of gives you a rough idea of what your LV function is, even though it's a right heart catheter. And then it gives you a good idea of what RV function is, and you can measure SVO2. But with echo, we can get most of that. It's usually intermittent rather than continuous. We get a better idea of what LV function is because we can image it directly. we don't get a really good idea of RV function, but usually we're more interested in the size than the function, and we can't get SVO2. So if you put in, you want that measurement, you can put in a right atrial catheter and measure right atrial saturation. Okay, so what are the roles for echo? We can do screening hemodynamics. This is an older slide, so but still is relevant. You may want to decide, based on your echo, to go on to more invasive hemodynamic monitoring. I have put in PA catheters in the last year. Okay, if you want to chat about why I think they were thrown out of the ICU for the wrong reason, then we can talk about that. But you don't get oxygen dynamics. And here's where I use it a lot. When I'm doing my semi-invasive monitoring, SVV, from FlowTrack, not SVV, SVV from FlowTrack and Cheetah are pretty reasonable because they're variations, but the absolute value of cardiac output can be way off. So I will validate that. If I'm using vasoactive drugs, I usually will get an echo before I even start or right after I start a vasoactive drug because I want to know what I'm doing. Do I need an inotrope? Do I need a vasopressor? And so forth. Extracardiac problems. So when we're treating shock, we use it to determine, do we need to give volume? Do we need a vasopressor versus an inotrope? Do we need both? Do I need a vasodilator? Do I have to be worried about maybe a significant PE? Should I send him for a scan? So echo should be part of your resuscitation. And the move now in cardiac arrest patients in the ED and for shock patients in the ICU is to use echo-directed resuscitation, which means not just one shot, but get a snapshot, do a therapy, get a snapshot, and keep doing that until you reach your goal. Okay? I think I finished on time. I did write a book chapter on these principles, so if you want to learn more about it, I can sell it to you for $40, or if you email me, I'll send you a PDF of it. This goes through everything I went through in a whole lot more detail, if you're so interested. Okay? Anything else? Appreciate it.